You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Scott MacDonald, Chief Medical Information Officer at the University of California, Davis. We talked about his path to becoming a CMIO, how he's leveraged artificial intelligence within various workflows, and how to fight back against the evil note bloat. We also discussed how tech adoption is uneven across medical specialties, how to do continuing education for physicians, and what exactly a PEP squad is. Let's plug in. Dr. Scott MacDonald, welcome to the pod. How are you, sir?
I'm doing just fine. Thanks for having me. Looking forward to this discussion.
Yeah, it's going to be fun. Where do we find you today? Where are you?
I'm at the University of California, Davis Health System in Sacramento, California.
Yeah. So is Davis and Sacramento, those are two cities that don't overlap. Is that correct?
Yeah, they're about 12 miles apart across a big flood project. Davis is a little small college town, but Sacramento is where most of the population is. So there's a lot more medical pathology here. So that's where we are able to do our medical school.
It's kind of false advertising, though. I think everyone would agree.
I would agree.
All right. Fair enough.
We sometimes will call ourselves the East Campus, and they're the West Campus.
So, all right. So we've established that UC Davis is not always really in Davis. I think that people are interested in that. They might also be interested in hearing about what you do at UC Davis. So you're the Chief Medical Information Officer. How does one become the Chief Medical Information Officer at UC Davis, located in Sacramento, California?
Well, first of all, you can become a doctor, but doesn't matter what kind of specialty you're in. There's lots of people that are CMIOs who are emergency physicians, internal medicine physicians like myself, you name it. There are various specialties. So it helps to become board certified in clinical informatics, which is another topic we could talk about if you haven't already on this podcast. So it's like having a second medical specialty that you do in concert with your primary one. And it certainly helps to have some interest or an enthusiasm for using health information technology to improve health and healthcare. And you don't have to be a programmer for that, but you have to have an interest in using IT tools to make things better. So if you've got those things, and some helps to have some leadership skills, some change management skills, those play a big role in my job. And if you got those, then you can get a job maybe as a medical director in informatics first, or you can be a physician builder or just an informaticist that works on projects. And then you can rise up through the ranks like I did and assume more leadership responsibility for informatics across an organization.
One of the things you didn't mention that I think you must be good at is getting yelled at by your colleagues. Is that not a key responsibility?
Well, I take a different approach. I'm able to sell things up front and phrase them in a way so I don't get yelled at very often.
Wow.
That's part of change management, right? Is building a reputation that you can actually solve problems for people. So people come to you and ask for help rather than yell at you for what somebody did.
Well, yeah, clearly we've established now multiple things. One of the new ones is that you are more effective at change management than I have been in my past 15 years. But let's move on to one of the ways that you help your colleagues. And this is what actually drew my attention. You and I have known each other for a long time. But I read an article that you were an author on about the PEP squad. And when I first saw that, I thought, wow, like that's cheerleading and something along those lines. But you don't typically see cheerleading articles in the scholarly journals. So what is the PEP squad at UC Davis?
Yeah, no pom-poms or flips on our team. It's what a lot of places may call sprint approaches, but this is a team, and PEP stands for Practice Experience Program. So really, we're all about improving the practice experience for physicians at Davis. and it has a couple different facets. One is about training. We know from a lot of data in the literature and in my practical experience that good training makes a huge difference in what people think about their EHR, and that also has a big impact on their burnout and their professional happiness. You can look at some of the class data that supports that statement. And so we recognized 10 years ago or so, well, no, 7 or 8 years ago, that we really needed to make an effort to really improve the training we were giving, mostly our physicians is our main area of focus, but we also help out other providers. But I'll use the word physicians. It's our main cohort that we train. And we also recognize that everybody is a little different. People have, they did pay attention to this part of class, but they missed that other part of class. So it's really about not a one-size-fits-all training program. We've really made an effort to tailor our training to everybody's individual needs. And we do that by having really a one-on-one or at-the-elbow model for training. We do two main things that drive the individualized curriculum for each physician. And that's a survey we give just to kind of get a feel for what they're bothered by. And it may not be something that they're particularly bad at based on data, but it's something that really sticks in their craw and makes their professional life quality poor. So we always try to address a few of the issues that they request us to help with. We also look a lot at data, and we use the EPIC signal data extensively to identify in what areas are they an outlier compared to their peers. So we'll look and see if they're spending hours after, in the pajama time, you may know that term, if they're writing their notes or if they're doing their in-basket work or whatever it might be. So we would prepare some lessons before our trainers meet with them to really address those specific areas that we know from the data that they're struggling with. So that's our main approach. We have historically done about a 4-hour training session once a year for each physician. And we don't block down their schedule for the entire half day, but we have them have a few patients there so that the trainers can observe them interacting with patients. And that's another opportunity where they can notice some inefficiencies in how they're both using the EHR as well as interacting with the patient with that third party in the room of the EHR.
All right. So there's a lot to unpack there. Let me start with just a basic clarification. So we're talking about ongoing training. We're not talking about a new physician to your practice. So that's correct, right?
We do both, actually. So
okay.
The bulk of our work really is all, our larger population of existing physicians. But we also team up with, we have a different training group here that does the bulk of the onboarding training for new physicians, both attendings and residents. So they do the initial day or two training. But then we have a plan where we follow up at 30, 60, and 90 days, where we do some additional pre-planned time with them to make sure that they're getting up to speed as they start with us. And then we'd have the annual training with them thereafter.
Okay. And for about how long have you been doing that annual 4 hours of training with every physician?
Yeah, that one I think we started, was it 6 or 7 years ago? I'd have to pull out the date. It's in that realm.
So, but that's it must be a very small percentage of healthcare systems that dedicate that much time in an ongoing way. The majority of places I've worked with, there's 0 hours of ongoing physician time, right? 0. So 4 hours for 5, 6, 7 years is a lot. Is this mandatory?
No, it's highly encouraged. And a few physicians don't take advantage of it. That frees up some of the time. We have a team of about 12, including trainers and builders and project managers that do the work. The harder part really is the resident training, because most of them are doing predominantly inpatient work through most of their training, and their ambulatory experience is more limited. So trying to get on, a schedule to protect time to do that for residents is difficult. So for residents, we tend to do more group-based trainings, doing a presentation at the didactic sessions that they have anyway as trainees. So we're still kind of exploring different options to get in front of residents and get them trained up. But So we haven't cracked that nut perfectly yet.
Yeah. So that's great. So so if I'm attending, I'm going to get an invitation about once a year, and it's going to say, hey, it's going to be a morning session or an afternoon session. You're going to ask me what are things that I find that I think I need help with. And then you're going to look at all the data points that you get from the EHR vendor about how I'm doing, which might actually contradict everything that I've just told you. Like, hey, I think I'm struggling in documentation. And you might come to the conclusion that I'm really good at that, but I'm really bad at ordering or something along the lines. And then you got to figure out, okay, how are you going to hit both of those things in 4 hours?
We've evolved that a little bit. We're doing some shorter sessions now. And we also have a trainer sort of assigned to each clinic. So everybody in a clinic has a person that they can go to if they have a problem, who can come out and work with them elbow to elbow, or just send them some tip sheets, or depends on how complicated it is. So the protected time is still there, but it's smaller and kind of spread out. The scheduling people every year for 4 hours turned out to be very difficult. So we've kind of evolved the model a little bit. So we still have elbow to elbow training, but it's a little less.
And are they still observing the docs with 1 or 2 patients?
They'll offer. It's not mandatory, but they suggest it often. Let me watch your work with a patient.
I think it would be scary. Some of the things that you would find that that people are doing that they think this is the way I was trained. I'm sure of it. And you're like, that was really an inefficient workflow that you just selected for yourself.
Yeah, I used to do it when we first started. In my early days, when I had less responsibility, I would actually do some of that training for new physicians as they came on board. But I saw a lot of weird stuff, and I was able to disavow them of those workflows. So it was rewarding. But
yeah, often you don't even, just having physicians in the same clinic share workflows can be fairly clarifying. So even 2 folks who may not be, neither of them may be a power user, but I've seen Dr. A go like, well, this is how I do whatever. I do a referral for cardiology, and Dr. B were like, wait, how did you do that? And it's just there's nothing magical there. Just that, oh, well, I picked up on this thing about referrals, but I didn't, when you did your version, you have something that I didn't know about. And just sharing, even in an unorganized way is helpful. So what have been the results of the PEP squad?
Well, we also have, part of PEP squad is also system enhancements too. So we actually have, depending on how well we're staffed, a couple Epic certified builders on our team too. So we have, that's a bit more now on a sprint basis. So we'll have set aside weeks where the builders are going to be working with a given specialty or clinic. And we have sort of a menu of items that we can build that have minimal amount of governance around them, mostly things that aren't going to have impacts on the rest of the health system. So we can build new order sets and review tools and documentation templates and those sorts of things for a given specialty. And so we have that sort of time set aside with a given specialty too. So on outcomes, hard to get a lot of quantitative outcomes because there's so many other factors happening in the world of medicine and in EHRs these days. So we haven't been able to show clear changes to, for example, E&M levels or signal data about time in the charts, because that has so much more to do with the workload that's coming in and other factors like a global pandemic that was a big confounder for all of our data over the past few years. But certainly the soft results, the testimonials that we've got from our physicians are fantastic. And everybody really has found value in spending time with the trainers and getting new tools in the system for them. And they look forward to interacting with the trainers when they come around periodically through their clinics.
Yeah. Well, I think the key metric might be what percentage of people actually agree to this, right? This is not a required program. And so if I'm giving you my time, which is generally the thing I have the least to give, then clearly I'm finding benefit from it. Well,
yeah, I don't have that statistic on my tip of my tongue, but we've got it somewhere. We've got a lot of data.
Yeah, and it's great that the health system is seeing this as something that's really important, and putting the money into it. And I'm sure it's not inexpensive to have 10 or 12 resources dedicated to simply making sure the physicians are as up to date as they can be on the latest and greatest uses of the software, or the not up to date, not the latest and greatest of the basics that they were supposed to have learned at the first time, that maybe they didn't hear that part of the class or missed that part of the class.
Yeah, that's a really important point. When you're coming in to learn a new EHR, it's just a fire hose of information. People complain about how EHRs aren't simple like my iPhone, but healthcare is just a lot more complicated than a weather app. Well, weather's complicated, but looking at the weather is not, right? So there's no way anybody can really learn everything they need to learn during a couple days of training when they join us. So it's really important to have them be effective physicians, is to know how to do all the stuff. And also, we hope it'll pay off in terms of decreased physician turnover, because we know it takes, $500,000 to replace a physician who leaves, give or take. So we're hoping it's, in some way affecting those sorts of numbers and having an ROI. It's just hard to prove to the level that will satisfy a CFO.
Yeah. Yeah. Well, you're doing it. So congratulations so far. And if you want us to talk, myself and all of our listeners, we can talk to your CFO if you think that will be helpful. I suspect it won't be, but on behalf of all the listeners, we're happy to do that. Talking about other things that will make your CFO maybe happy, an AIScribe. See, I just transitioned us to an AIScribe. So you have kind of, it sounds like, gone all in on one particular vendor, and tell us what that AIScribe is, or what is an AIScribe first of all, and who's the vendor, and how's all that working out?
Yeah, so AIScribe is one of the names. You may also hear ambient listening is another term of art. But my take is that ambient listening doesn't mean much. It just sounds like somebody's eavesdropping. But this is actually doing something for you. It's using AI, obviously, but it's a scribe. So it provides a lot of the functionality that a human scribe might provide a physician. And in a little more technical detail, what it does is it's sort of like Dragon or one of the medical transcription voice recognition softwares that can record your voice, that you can then use to build your progress note or H&P, depending on your practice area. But in this case, the system that generates the transcript of the entire visit. So it's not just the physician dictating what happened, but it actually is capturing the patient's voice. And not only the patient's voice, but their families. So the parent's voice if it's a pediatric visit, or when I see a demented geriatric patient, it's the patient's children that are giving me the history. And all that's captured by the transcription part of the AIScribe software. And then the next phase of the software is it takes that transcript using a large language model to convert that transcript into a progress note. So the few minutes I would spend for every patient before writing a note, now the system will generate a note for me that I just edit, make a few corrections and changes. So it saves me quite a bit of time, couple minutes on average across the board. And then I can just edit that note, sign it, and I can go. We're using a vendor called Abridge, which is one of the kind of two that were initially out of the gate that were more integrated with Epic. Nuance, which is the Dragon company owned by Microsoft largely now, was one of the other vendors. But we went with Abridge. We did a pilot with them this summer with 30 physicians, and we found pretty good results. We measured a lot of things about time in the system, the quality of the notes as rated by the physicians, what patients thought about it, if improved their ability to engage with each other during the visits by taking that third entity out of the exam room, and generally got good results on all these. So for now, we're going to go ahead and roll out to our attending physicians for now. Anybody who wants it, it's not mandatory to use it. We find that it's a lot better in certain specialties than others. So as long as our budget lasts, we'll be able to provide this to as many physicians as we can get it in the hands of.
And does it, so you said that you're using it, and we're talking outpatient, I'm assuming. We're talking in the clinics.
Yeah, primarily it's Abridge cells that they're good for quite a few different specialties in the ambulatory space, and then they're about to release official support for the emergency department. But they're working on inpatient as well. Workflows are a bit different there, especially in an academic health system where there's a lot of members of the team gathering information from different places. It's not all verbal information from the patient. So it may work. It may still end up working better in ambulatory because so much of that visit is verbal in that exam room where you can actually capture the words. It kind of leads to one of the awkward pieces of AIScribe that's vendor independent, which is, it doesn't know what, when a patient says it hurts right here, it doesn't know that. Or when I hear a murmur, it doesn't know that. So it has to change the dynamic with the patient quite a bit, especially during the exam, to say, okay, I'm going to be talking to the computer now. You don't need to answer me or ask questions when I talk about RALs and right upper quadrant masses.
Fair enough. And have you gotten used to that being able? So you have to kind of essentially have to dictate your physical exam, either as you're doing it, or afterwards, and then okay, and how have patients reacted? Obviously, you're telling them that you're going to be recording them and why and how it benefits them and you, and how do they react?
Generally pretty good. California is a two-party consent state for recording, so we have to get verbal consent and document that in the record each time. But we have some flyers up on the walls so people can read about it. And so that way we don't have to spend a whole lot of time describing the system in detail and wasting precious clinical time. But most people are agreeable to it. I tend to read the body language, and if somebody looks at me a little askance or seems uncomfortable with it, I won't use it. But the majority of people think it's pretty cool. And based on our patient survey data, a lot of patients feel like it's really improved the engagement and the interaction with the physician, just because I don't even log into the computer oftentimes anymore. I'm just sitting straight in front of them, looking them in the eye, because I know something else is taking care of my documentation, so I don't need to worry about that.
Awesome. And is this your phone that's doing the recording? Where's the recording being done? Is there a device in all the rooms?
Nope, I'm just using my phone. I use the mobile app that our EHR vendor puts out, so it's embedded right in there. So I don't even need a separate app for it.
Okay, and as it's made you faster, it sounds like since it sounds like the note comes out fairly complete from your perspective.
Yep, it takes about a minute or so for the note to be generated, minute and a half maybe, and it's usually pretty accurate. We have we came up with a note quality scoring mechanism, and it was 3.9 on a 4-point scale, basically on a sample of 300 notes that we gave. Most of the kind of quote errors are fairly small and inconsequential. That might even really be interpreted more of a matter of style rather than medical accuracy. There's the occasional mistake where it thought it was a different drug name that it had interpreted wrong. So I have to make sure those are all correct. But it gets 95+% of those correct when I'm talking about obscure drug names.
Okay, fair enough. And so you're expecting to make this available to all your physicians, and and some of them will use it, and some will think that they're doing fine. Sounds like.
Yeah. Place specialties who have a lot more structured documentation. Like ophthalmology is one extreme example where a lot of their notes is all just, intraocular pressures and refraction indexes and things like that are just not spoken. So it doesn't make sense to use AIScribe for a lot of ophthalmology. If it's an area or patient complaint that's a lot more functionally based, like how is your vision impairment affecting you? Well, that might be better to include AIScribe for. But certainly primary care, where we're taking the initial history and exam and trying to figure out what's going on with the patient, AIScribe works real well. Places in the middle might be orthopedics. We're going to test that out. I think they're starting some of them this week. And so, a lot of their database is based upon their imaging and history, but less about a detailed history of present illness from the patient, like an internist would use. So it's interesting to see how the different specialties work. Dermatology is very photograph based. There's not much history there, so AIScribe is not terribly useful. Sometimes useful, but not terribly for them.
Yeah, no, that all resonates. I was gonna start making jokes about ophthalmologist notes, because ophthalmologist notes don't make any sense to any physicians besides ophthalmologists. I'm not even sure it makes sense to them, but
yeah, I use a large language model to help interpret ophthalmology notes.
Yeah, that makes that actually resonates with me. And then when you were talking about dermatologists, I remember as I think I was a resident, and I was doing a month of dermatology, pediatric dermatology, and I went in to see a patient and came out to discuss it with the attending before the attending followed me in, and I said, "It looks like this, but it can't really be that because the history's all wrong." And he looked at me, he goes, "History? What do I care about the history?" And he, walked in and said, "It's exactly what you thought it was at first, and the fact that the history of the way the rash presented, it's irrelevant. It's what do you see?" And so that resonates a lot.
Yeah, it's still psoriasis no matter what.
Yeah, it's not going to change if it's itchy or not itchy. I can't convince them that it's not that. So one of the things that you talked about was note quality. And you had mentioned when we were preparing for this that you have kind of a program called the Note Matrix program, where you kind of go over do's and don'ts for documentation. Is that still necessary if this if ambient listening and AI scribing becomes uber successful, or is that something that the old folks like myself who put notes together manually care about?
Yeah, no, it's still relevant. So that the Note Matrix program is it's one of the projects of the PEP Squad, actually. And so we put a lot of work into a really multidisciplinary group to figure out what should be in a note and what shouldn't be in a note across the whole enterprise. So this is, discharge summary, admission H&Ps, progress notes, discharge summaries in the clinic, the hospital. Because we all know there's a huge problem with note bloat over the past decade or two. It's so easy to add a lot of text to a note or copy forward from previous notes. And it leads to not only potential inaccuracies in the notes, but they're really hard to read. And they're time consuming for the note audience to read. And so we wanted to try to get those tightened up so that the notes can serve the many purposes that notes have to serve, which is, chiefly is documenting what you did and what's going on, communicating to your colleagues on the care team. But, to be honest, it's a lot of other things. And we kind of recognize those and brought representatives to represent those points of view. So there's, the compliance piece. What do we need to document to comply with federal and state law? What do we need to get in there to capture quality indicators for our quality reporting improvement efforts? What needs to be in there for coding so that we can bill and get paid for the work we're doing? What do the patients need to see? Because now, since the 21st Century Cures Act, our patients are another audience of our notes. So we're trying to get all of these constituencies of the note. So we got all their voices in our matrix. So for each progress note type, we've got one column of all the different things that historically have been in notes. And then we have commentary to say this has to be in there, or this can be in there, or this shouldn't be in there. And then what we've done to support that is we build tools in our EHR to help make it easy to do that. Not just templates, which are hard to get people to use a system-generated entire note template, but rather we put in the modules from the template. So we've got like a really good way to record or to summarize social, medical history, that sort of thing. So we've created smart links, and a lot of them are using some of the like hover bubble smart links now that you can cursor over it. It'll show you a big block of text, but it's not text that really needs to be in the final note. Other people a year from now aren't going to want to read that. So we've done what we can to minimize the amount of actual text that's in the note while still making the function of chart review, which is actually also a function of a note, this is also kind of where you review information about the patient by bringing it into your note. So we're trying to walk a fine line between supporting that note review function along with all the other people who consume the content of it. So, and now it's another big change management process. So now we're going to be leveraging our PEP squad again as we work with physicians, either as they're getting onboarded or we're working with them throughout the years to say, hey, we got these new things that we'd like to, let's work with you and tighten up your note templates that you use every day. It'll make them easier for you to write and easier for other people to read. Now, going back to the AIScribe piece of that, the AIScribe generates sort of discrete blocks of text. It doesn't generate the whole note per se. So it gives you a chunk that's the HPI, and it gives you a chunk that it's the physical exam, and a chunk that's the assessment and plan. So most of us then will use those chunks in our kind of pre-existing note templates. So our pre-existing note templates may have other things in there. Some people put those disclaimers about inaccuracies, or they put notes to their patients who are reading the notes to help them interpret it. Or they may bring in smart links to have some data that automatically comes in for them to review that I just referred to. So all that stuff still works using AIScribe. It's just those chunks where you used to have to either type or dictate an HPI. Now that section is being populated by the AI, and those are the most time-consuming chunks to generate.
Yeah. What I love about this, besides it being incorporated into the PEP squad, is that you're kind of following some of the principles of human-centered design, right? As you said it yourself, make it easy. You want to make it easy to do the right thing. So oftentimes, what groups do, in my experience, is they'll write a document. Hey, this is what should be in this note. This is what should maybe be in this note. This is what should never be in this note. And then they email that document to you. And that's fabulous. But you're not making it easy to do the right thing, because I read it, but then I forgot it the next day when I need it. And when do I need it? Well, I need it right when I'm writing the note. And so kind of making that easy for me to get and kind of incorporating it into it, so I have very little work to do. That's the way to go. So that sounds good. And I think it's smart that it's not just the, you're not kind of putting your hands up and going, well, the AI, the LLM is going to write the note for us, so it doesn't matter anyway.
Yep. Yeah. Because a lot of the problem is getting rid of stuff. And in fact, the AIScribe's a little bit verbose for my taste. I tend to write fairly curt notes. So my notes actually got a little longer, but I'm still spending less time doing them, and I have a lot less mental exertion at the end of the day. So it's still a win-win.
That's great. So let's start to kind of close up. I just wanted to kind of talk about art, and I don't mean art, the stuff that we draw and sculpt, but art, which is an epic product, or the name of an AI that kind of helps physicians start the response to a message. And so you guys have been using it. What do you think? I understand it's kind of early days, but does it actually help you?
Occasionally. Yeah, I just thought of a cheesy joke. So it's the art formerly known as draft in basket responses. Play on our purple friend in Minnesota. So what it does is basically on the first incoming MyChart, patient portal message from a patient, we can generate a prompt that goes through Epic's pipeline that sends that message from the patient with what other information we choose to send along with it to OpenAI is what actually does it. And that prompt tells the AI to generate a response, that the kind of response that we want. And so it works. It's sometimes and somewhat helpful, I would say. It does more than anything. It provides sort of a draft that you can get started with, and it provides some of the social niceties and maybe a sentence or two that are useful. But it doesn't make medical decisions. You still have to look at all the data that's appropriate for the question, make a decision. You still may need to place orders, fill in specific details. But it can provide sort of a skeleton or a framework for you to generate your response to the patient. And because the LLM can be a little more empathetic than a human can be, because it has the time, those extra microseconds to generate the "Hi, how you doing?" type stuff. I kind of appreciate that. That's stuff that I could type out, but it's going to take me a couple seconds to type all that stuff out. So if the LLM does it for me, great.
Yeah, I when I was a medical student, we didn't have LLMs back then, Dr. MacDonald. Let me assure you, but I was seeing a dermatologist, and he walked in, and I hadn't seen him in a long time, and he asked me how a vacation had been like a year prior, and I was like, oh my gosh, I can't believe you remembered that. That was such a. And then I saw on his note that his medical assistant, who was scribing for him, had written down that that I was going on vacation, so he had just read the note from a year prior, and I was like, it's kind of cheating, but it's also kind of brilliant. And so, yeah, if you can have a computer kind of move in that direction. Now, to be clear, just in case anyone's listening, this is a private LLM, right? So you're not actually sending patient data that's available to OpenAI. It's all kind of behind a firewall, as I understand it.
No, we send what we want to send. The LLM doesn't have access to the chart per se, but if we want to send a medication list for the patient, along with a query that's about a medication issue or a refill, then we can send the med list with that.
Okay, yeah, because there's no private information there.
But the system also categorizes the incoming messages into 4 different types, so we can send a LLM prompt for each of those different types, so we can fine tune our prompts a little bit to get appropriate responses. So that's something we're hopefully going to get to more this year, is working on making those prompts a little bit more effective. There's some Epic tools called the prompt engineering testbed that we're hoping to get some of our informatics physicians involved in, and learn about how to do prompt engineering more effectively, improve the output of this.
Yeah, prompt engineering is the new term for programming, as someone said.
It's like natural language programming, because you don't have to follow any particular syntax. You just have to tell it what you want, and then it, like an eager puppy, it tries to please you.
I have never heard an LLM referred to as a puppy, but you're not far off there with that metaphor. I love it. Awesome. Well, this has been a great conversation. As you know, we love to end the conversations that we have with a question about design. Is there something in your life, or are there some things in your life that are so well designed they bring you joy when you use them? And so, Dr. MacDonald, is there something in your life that's pretty awesome, and it's because of the design?
Yeah, I think so. And it's my own thing that I designed, but I use it every day. And it's a combination of my home automation system and 3D printing. So I'm kind of a coffee snob, and I roast my own coffee beans, and I brew a pour over every morning with just the right temperature. So my electric kettle is really good at maintaining a good temperature, but it doesn't have a remote turning on functionality. So I was able to find it's basically called a fingerbot. So it's a little home automation device that has a little finger that comes out and just presses down. And so it can press the on button for my hot water kettle. And so in order to get the finger to hit the button in the right place, I 3D printed a little piece of plastic that clips onto the hot water kettle, just so that finger is right in the right place at the right height and centralized over the button to turn it on. Now, if I still have to, press a button on my phone to get that to happen, that's like I have to expend 5 calories to do that. So we don't want that. So then I built, a home automation connected to my wake up alarm on my phone. So whenever my alarm goes off, it automatically turns on some lights. It tells the fingerbot to turn on the hot water so that by the time I wake up a little bit and go downstairs, the water is hot and ready for my pour over.
That is, that's impressive. And the fact that the plastic doesn't melt, so it must not get too hot on the hot water.
Yeah, it's far enough away. And if it melted, I could just use a different type of filament that's a little more heat tolerant. So, but the one I use works fine.
All right. And so then you have coffee that's you're pouring it over at the exact right temperature because it maintains that.
Yeah. So freshly ground beans that were roasted within the past few days. And then I just pour. Yeah. And then it's basically chemistry. I was a biochemistry major. So it's just basically an extraction. You're just trying to extract as much of the volatile flavor compounds and caffeine from the grounds. So you got to have the right surface area to volume ratio of the grounds, the right temperature of your solvent, the water, and the right dwell time. And all that stuff is what makes a really good cup of coffee.
So what time should we be at your house to try some of this coffee?
About 6:30.
6:30. Yeah. Okay. All right. I noticed you're not giving us your address, but so we'll work on that part. But wow, that's cool. Yeah. So your favorite design is your own design, and I think that's probably true for many of us.
Yeah, and it combines a lot of just the things I'm interested in: 3D printing, CAD, home automation, computers, coffee. It's all wrapped up in this one little package.
It's all right there. That's awesome. Well, it has been a pleasure talking with you about all the cool, fun things you're doing at UC Davis, by the way, which is found and located in Sacramento. Appreciate the time and thanks for all the work that you're doing. And I think a lot of it, you're kind of you're moving away some problems for the rest of us, kind of proving that, hey, some of these things do make sense financially and helping physicians and clinicians in general become less burdened and get back that joy of medicine and that ability to actually do what we all went to school to do. So on behalf of everyone, I say thank you, and we appreciate it.
You're very welcome.
Thanks for tuning in. We hope you enjoyed today's episode. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.